Hi everybody, I'm Ashwin.
I'm Raj.
And I'm Eddie.
This is Blood Cancer Talks. This is a podcast exclusively dedicated to hematologic malignancies, where we bring content experts who live and breathe a particular disease and focus on the latest advances in biology and clinical development. Today we are excited to talk about management of FLT3 positive AML. We have an expert, Dr. Alexander Perl, Associate Professor of Medicine at the Hospital of the University of Pennsylvania. Dr. Pearl, thank you so much for joining us and thank you for your time. Before we can start, can you tell us about yourself, your clinical and research focus for our listeners?
So I've been at Penn for about 20 years now. I did my medical school prior to that at Mount Sinai, residency training at UCSF, fellowship at Johns Hopkins, and that's where I first got interested in the topic of FLT3 mutated AML and targeting FLT3. I had worked there with Don Small, who was the person who first cloned the FLT3 gene, and closely with Mark Levis, who was developing clinical trials with drugs targeting this receptor tyrosine kinase. So, as a fellow, I was actually, on the leukemia service when some of the first patients were treated with FLT3 inhibitors. And it was a really exciting time. This was, within very short order of the first approval of imatinib, Gleevec for CML. And so suddenly our field was really transported into the molecularly targeted era. And it really opened up the idea of finding the same kinds of targets in different kinds of malignancies, and just, figuring out which were the drugs that were active against the targets, validating the targets, and trying to improve therapy for patients. And then when I moved from Baltimore to Philadelphia, I took those interests with me and have developed that over the years. I've been involved with a number of early phase trials of a number of FLT3 inhibitors. Some went nowhere, some went all the way. And that's been an exciting ride over the last 20 years. But I don't think we're done trying to improve therapy for patients with FLT3 mutated AML. We're certainly doing a lot better than we were 20 years ago, but we've got a ways to go. But it still is exciting, and I think we're still making important strides.
Fantastic. Thank you for that introduction, Dr. Pearl. So let us jump right in. We'll start with the case and you can walk us through how you would approach this patient and we can discuss the data as we go. So this is a 55-year-old man with a history of hypertension, coronary artery disease and hypothyroidism, presented with fatigue and dyspnea on exertion. A complete blood count at presentation showed a white count of 100,000 and a hemoglobin of 10.5 and a platelet count of 42,000. After initial management of this suspected acute leukemia, he underwent a bone marrow aspiration and biopsy, which showed a hypercellular marrow with greater than 90% cellularity consisting of myeloblasts, which showed an abnormal immunophenotype by flow cytometry. Cytogenetics showed normal male karyotype, and the myeloid NGS panel was done, which showed FLT3 ITD at a variant allele frequency of 36% and a IDH1 mutation at R132 at a variant allele frequency of 48%, as well as the presence of NPM1 mutation at the variant allele frequency of 29%. So in a patient like this, you see in the hospital, how do you approach this case of a new diagnosis of FLT3 positive AML? Can you please walk us through your thought process and how you approach a patient like that?
I think this is a very typical presentation of this disease. A number of things here point to, the presence of a FLT3 ITD, even if you didn't know the genetics. First off, it's occurring in a middle-aged person. These mutations are more common in, younger aged group than older age group, though they can occur at any age. They're commonly associated with high white blood cell counts, high blast percents, both in the blood and the bone marrow. So seeing a presentation with hyperleukocytosis, 90% of the marrow are myeloblasts. That's very typical. And also genetically, FLT3 mutations commonly occur in combination with certain other mutations. They're pretty rare in combination with TP53 mutations or complex karyotype. More commonly, we see them with diploid karyotype or normal karyotype. And they often are associated with NPM1 mutation. And so they, in general, make the otherwise very favorable prognosis of NPM1 worse. And it's been debated just how much worse, and that also can be genetically context-driven. In combination with an IDH1 mutation, I would say this falls currently into the ELN intermediate risk category. The prior iteration looked at the allele burden of FLT3 ITD, which you can't actually tell by the variant allele frequency by next-gen. You need a PCR to tell that. And one of the challenges with that classification was there wasn't an agreed-upon assay to say across the board, how do you define this patient as favorable risk, intermediate risk, or adverse risk? With a VAF of 36%, that corresponds to an allelic ratio that's close to 0.5, actually. One mutant copy for every 2 wild type. If you do the math, that's about 33%. So it's right on the borderline. So this person likely would wind up in the ELN adverse risk group by the 2017 category. Nowadays, we just say everything's intermediate. That being said, that's intermediate using very aggressive treatment paradigms. And you have to be aggressive, these patients, because these folks can go from well to sick very quickly. They often have rapid doubling times. You don't get to a white blood cell count of 101 from nowhere. And these patients can, with very little provocation, double their white count every 24 hours. So they really need to be watched closely. I would initiate this patient on cytoreductive therapy. Typically, we give hydroxyurea to make sure the white count doesn't rise further. If the dyspnea we think is due to leukostasis, there's great urgency to bring that down because that can impact induction mortality. You need to think about getting a diagnosis quickly and initiating therapy quickly. And we don't wait for the genetic confirmation of a FLT3 ITD to start the patient on, say, 7+3 induction. Once we know they have AML and the patient is fit for induction chemotherapy, we initiate it, and then we send off the genetic studies that we hope will come back in a few days. Now, I don't see a PCR here, which is my preferred study at initial diagnosis. And that's because our next gen, at least in our lab, takes a while to come back, and a PCR is faster. So with that, we can know within the 7 days that we're giving IV chemotherapy, we start with 7+3, whether the patient has a FLT3 mutation, and then if so, we start a FLT3 inhibitor on day 8.
You touched on very important points. I think one particular question I had is, at the time of diagnosis, you always send the PCR for ITD as well as TKD?
Yes, I do.
Okay,
Yeah.
both of them.
Yeah, because it's going to drive your choice of drug. Now, actually, that there are 2 drugs approved for this disease, I think it's particularly important. And also, there was a benefit to giving midostaurin in the FLT3 TKD positive patients. In fact, that was the group that primarily drove the survival benefit on the RATIFY study. So I think it is actually important to look for the FLT3 TKD positive patients, even though they don't generally have as sinister an outcome. That's also context dependent. On RATIFY, the phase 3 study of midostaurin, the vast majority of the patients who had a FLT3 tyrosine kinase domain mutation, so-called D835 mutations, were actually ELN favorable risk, either core binding factor or NPM1 mutated, and again, generally did not have a FLT3 ITD. It's pretty rare to see those 2 FLT3 mutations in the same leukemia. You usually see one or the other, though often there's multiple clones of each mutation. So, if you see a NPM1 FLT3 TKD, that patient can do very well with existing therapy, but they do even better when you add midostaurin. And importantly, with the most recently approved drug for FLT3 mutated AML, Quizartinib, that drug's not actually active against FLT3 TKD mutations, and we have no data that it's beneficial in their care. It may be, but it's really not been studied. So we don't have a lot of data to say that it's better than using midostaurin in anybody with a FLT3 TKD. I really think midostaurin is the drug of choice in that setting. So yes, I would use a PCR to see either FLT3 mutation that can be picked up by that assay. And there's rare mutations in FLT3 that activate the kinase that you won't pick up by PCR. We'll get those on next gen. And how much a FLT3 inhibitor adds to the treatment effect is less well established. I think it really does matter per mutation and which drug you're using.
And especially if there are presence of other mutations such as NPM1 or in this case IDH1 mutation, do you monitor the PCR over the course of the treatment, or do you rely on NGS as well, given that there are other mutations present in this particular patient?
So in a patient with an NPM1 mutation, I think we have good data that we should follow the NPM1 burden, typically in peripheral blood and typically after 2 courses of intensive chemotherapy, with this recommendation coming from mostly European studies, a well-known study from the UK NCRI, led by Ad Ivy, that was published in the New England Journal, I want to say about 2016 or so, showed that the continued presence of an NPM1 mutation in remission was a strong predictor of relapse on that study. And that was true, in the FLT3 ITD positive population, or those who were wild type for FLT3. All the patients studied on that report had NPM1, and that's what they looked for. And the question is, if you don't have an NPM1 mutation, what should you follow? So that's an evolving field. There's an emerging story for following FLT3 ITD burden, which, you can do that by PCR, but a more sensitive assay is preferred. And even the next-gen sequencing assays probably aren't sensitive enough to define an MRD positive versus MRD negative population. There are more sensitive assays, which I'm sure we'll get to as we talk about other trial data that have been recently presented, such as the Morpho study. We did collect MRD data on the Quantum First study. I'm an author on that paper and was involved in the trial. And it was important for that purpose to say, is this something that's predictive of outcome on the study? And indeed it was in both arms. If you were MRD negative by measure of a ultrasensitive FLT3 ITD allele burden test, which combined a PCR amplification of the juxtamembrane and then sequencing of the products by next generation sequencing, that test was a strong predictor of survival on that trial when patients were in remission. And also we looked at it prior to transplant and gathered data on that as well.
The next question we had is, what are the different types of FLT3 inhibitors? We hear a lot about type 1 and type 2 FLT3 inhibitors. What are those, and what is the difference between the two?
Yeah, so it has to do with how chemically they inhibit the kinase. And this is true for tyrosine kinase inhibitors in general. You may recall, if you think back to imatinib versus dasatinib, imatinib is a type 2 inhibitor of BCR-ABL, whereas dasatinib is a type 1 inhibitor. We think of some of the weaknesses of imatinib in terms of the likelihood of developing resistance mutations in CML, because the binding of imatinib to its target can be easily weakened by very minor variations in the binding region on the BCR-ABL protein. And that's true, in terms of a weakness of type 2 inhibitors of FLT3 as well. At a chemical level, we're talking about the difference between binding an active versus an inactive conformation. The type 1 inhibitors can bind both. The type 2 inhibitors only bind when the kinase is inactive. And so an activating mutation at the catalytic domain of FLT3 will render a type 2 inhibitor insensitive. The kinase turns back on, the leukemia continues to grow. And the examples of this include Quizartinib, which is a type 2 inhibitor and is only active against FLT3 ITD, but not those activating mutations in the tyrosine kinase domain, such as the TKD mutation. It's also true for sorafenib, which was commonly used as a FLT3 inhibitor prior to the approval of Quizartinib, which is brand new. So we certainly have a long history of using sorafenib. It's never been an approved therapy for AML, but it's relatively commonly been used off-label. And it is active in that disease, and there's a long history of using it, particularly in the context of transplant and post-transplant maintenance.
You mentioned briefly, but we want to come back to the RATIFY study, CALGB 10603, where midostaurin was added to 7 and 3 induction and consolidation therapy compared with placebo for FLT3-positive AML, including patients with FLT3 ITD high, ITD low, and FLT3 TKD. Complete remission rate at treatment day 60 occurred in 59% in the midostaurin arm and 54% in the placebo arm, and the median overall survival was 74.7 months in the midostaurin arm and just 25.6 months in the placebo arm. So how do you determine in whom to add a FLT3 inhibitor? Does everyone with a FLT3 mutation receive a FLT3 inhibitor?
So let's be clear, this is intensive chemotherapy of patients under the age of 60. That's who was treated on the RATIFY study. And when they designed the study, they set an endpoint that required a complete remission be declared by day 60. In reality, that was probably too early because there were patients who needed 2 cycles of chemotherapy, and the count recovery on the second cycle could happen after day 60, and you wouldn't capture that. So if we look at everybody on that study, the CR rate, again, with full count recovery was closer to 70% in the midostaurin arm. It wasn't a lot higher than the placebo arm, but it was actually higher. I want to say, the placebo was, I think, about 61, 62%. So it was better, although not hugely better. The median overall survival looks much, much longer with midostaurin, but then if you look at the survival curves, they basically flattened out at about just over 50%. So it makes this big artifact that makes the median survival look much better with midostaurin. And so most people in the field look at the 4-year survival that was reported, which was 51% in midostaurin. 51 in midostaurin versus, I believe, 44 in the placebo arm. So about a 7% absolute increase in overall survival. And the hazard ratio was 0.78, meaning there's a 22% reduction in the risk of death. So it's better. It's not hugely better, but it's better. And the big question is, does that add toxicity? Is there an important downside to midostaurin? And there really wasn't. So to answer your question, if somebody is fit for induction chemotherapy, we're going to treat them intensively with 7 and 3. I think we have convincing data from CALGB 10603 or RATIFY that midostaurin improves the survival of patients who have a FLT3 ITD or TKD by PCR. So that has become the standard of care worldwide and has been, since midostaurin was approved in 2017. And the only data to really challenge that in terms of what we should do frontline have come from the Quantum First study that was, just reported about a year ago and published in the past few months. Which showed, very similar findings in a FLT3 ITD only group that went above age 60, actually up to age 75. But again, patients who were fit for intensive chemotherapy. And these studies are not defining, what should we do for everybody. They were only defining what should we do for people who have these particular mutations and are fit for the intensive chemotherapy. And there are some differences in these 2 studies in terms of their design, not just the age of patients that were included. Again, RATIFY allowed TKD mutations and ITD mutations, type 1 inhibitor that's active against both. Quantum First is a study that only allowed patients with FLT3 ITD because the drug is only active in that group. And a big difference on this was how the maintenance was set up on the study. The maintenance was much longer on Quantum First and was allowed in people who went to transplant. They didn't have to leave the study to go to transplant. So the midostaurin was added for 14 days on each course of chemotherapy on RATIFY. So that was true of up to 2 cycles of induction, 4 cycles of consolidation with high-dose Ara-C, and then a year of maintenance versus a year of placebo maintenance in the other arm. There was no crossover on either of these studies. In Quantum First, same design in terms of 14 days of tyrosine kinase inhibitor, given on up to 2 cycles of induction, up to 4 cycles of consolidation. But if patients went to transplant, they didn't go off study. And so if patients went to transplant on Quantum First, they could return to post-transplant maintenance therapy and receive that for up to 3 years. If they didn't go to transplant when they were finished with consolidation, again, up to 4 cycles, whatever the investigator thought was most appropriate, they could receive the maintenance therapy then and there. So there was a good adherence to the protocol assigned therapy, which was much longer in Quantum First. And also we have the transplant data. We don't have any post-transplant maintenance data from RATIFY because that was not commonly done when that study was enrolling. And so, that is one important difference between these 2 data sets.
One question, Dr. Perl, is do you think that the Daunorubicin dosage matters in treating FLT3 positive patients? RATIFY trial used 60 milligrams per meter square, but do you think 90 is better than 60?
Yeah, I don't actually know the answer to that because it's never been studied. I think in the pre-TKI era, there are multiple studies that have shown that a dose of 90 milligrams per meter squared of Daunorubicin beats lower doses, and even one study that showed it was better than Idarubicin in the FLT3 ITD positive group. So a UK study showed that, a US study showed that, and a Korean study showed that. all with very consistent data. This was challenged recently by a German study that showed no benefit of 90 milligrams per meter squared over 60. Again, none of those studies used FLT3 inhibitors. So now that we're not giving just chemotherapy, but we're giving a FLT3 inhibitor, nobody really knows the answer. What I can say is that 90 milligrams per meter squared of Daunorubicin plus a FLT3 inhibitor is safe, and that's been done on actually two studies, a study of crenolinib, a drug we haven't mentioned so far, and a study of gilteritinib, which is a FLT3 inhibitor that's approved in relapsed and refractory patients, a type 1 inhibitor. And so there have been studies using as high as 90 milligrams per meter squared with FLT3 inhibitors, and it's tolerable. We just don't know if it's better. I think, if you weren't using a FLT3 inhibitor, I would argue, more intensification of anthracycline is important. But now that we do, it's less clear. And as we come up with combination regimens, avoiding toxicity, particularly myelosuppression, is important. We don't know that there's more cardiotoxicity with this approach. I think that's been the big concern with higher dose of anthracyclines, but actually it hasn't really played out that way in the clinic. So at the end of the day, the answer is, gee, we don't know. We'll have to see how this all plays out.
Another point I wanted to ask you about is that I think the RATIFY trial excluded patients with a ratio of less than 0.05. Do you include those? Do you give those patients a FLT3 inhibitor?
I don't know if it benefits them. I mean, we don't know from studies whether these patients should be lumped together. It probably doesn't harm them, but we just don't know a lot about that. It really just comes down to the question of, what else are you doing? If you follow these patients, it's actually not uncommon that if they do relapse, they have a FLT3 mutation if they didn't get treated with a TKI frontline. And I think this whole question of allele burden is a little bit tricky because a FLT3-ITD is very specific for a leukemic clone. It's not, clonal hematopoiesis. It's not a CHIP clone. It's a late hit in leukemogenesis. And that's different than even a FLT3-TKD. You can spot low levels of FLT3-ITD and be pretty confident those are leukemia rather than, sequencing noise, which is true for point mutations, as, all of the FLT3-TKDs are point mutations. They're not insertions of specific sequence, which is what we see with an ITD. And so we can be very confident that an ITD read really is leukemia. So, if people have really low burden, what we don't know is FLT3-ITD a driver in their leukemia if it's a minor clone? And I suspect those are the patients that have generally more favorable and chemosensitive disease. When FLT3-ITD is in the major clone of the leukemia, those tend to be the bad actors. So I don't think it's wrong to add a FLT3 inhibitor in that setting. I just don't think we know whether it's better.
You briefly mentioned about Quantum First trial where they included patients up till 75. Although the caveat is this study was started much before venetoclax plus azacitidine was approved. Right now, if a patient between 60 and 75 presents to the clinic, probably you will go ahead and start aza-ven versus giving them an intensive therapy.
I think that depends. If somebody walks in looking like this other patient with a white count of 101,000 and they're dyspneic and they're very sick, and I'm worried I can't cytoreduce them with hydroxyurea, I might give them intensive chemotherapy if I think they are able to tolerate it. I don't hold back when I think the patient is fit enough to receive the therapy. If someone's truly unfit, it's not going to benefit them, and we use any way that we can to cytoreduce them, usually with other chemotherapy, before starting aza-ven. But we do generally make a fitness determination before starting therapy. And I think we can't say what the right therapy is for older patients because to date, there has not been a study in the older population where 7 and 3 and a FLT3 inhibitor beat a comparator. There's no randomized data that says that clearly it's better to give a FLT3 inhibitor. We can look at the Quantum First data and say, the study overall included patients up to age 75, and it showed a survival benefit that's real, in the FLT3-ITD positive population that was studied. But if we look at the subgroup analysis, the survival benefit was almost exclusively driven by the outcome in the younger patients. And the outcome in the older patients actually looked like the induction mortality might be higher, that there wasn't a big improvement in survival. I think the hazard ratio was like 0.9 something. So it's a little bit of a question of, were patients who weren't really fit for induction put on that study, Or is this just a really hard population to show a survival benefit? And a FLT3 inhibitor can do all it can do, but it doesn't improve outcome. And maybe it's a Quizartinib thing and a different FLT3 inhibitor would do differently, but we haven't proven that adding a FLT3 inhibitor is better. Now, do I do it? Sure, I do it. I do add Midostaurin, or I could use Quizartinib now that it's approved in this population. But I do it very cautiously, knowing if I'm pretty confident this person can withstand the rigors of intensive chemotherapy, that I just want to give them the best regimen so they don't wind up with resistant leukemia at the end of the day, and they're not harmed by the therapy. If I want to get that patient to transplant, which is often my goal, I don't want to get them, through induction, have them come to see me in the clinic in a wheelchair. I need to have them well enough that I can take them, very soon thereafter to a transplant if that's going to be definitive therapy. And that's often how we're looking. The advantage for me is that, a round of intensive chemotherapy is a good test run for a transplant. But whether we do that during induction or post-remission, it hasn't been proven which one's better. So I don't think it's wrong in any way to use aza-ven in somebody who's borderline or clearly unfit. And if they get better on that therapy, look at intensive therapy thereafter.
Yeah, that's really a helpful way to think about that middle group of patients who aren't clearly fit or unfit right from the get-go. There are two kind of elements of the Quantum First trial design that you mentioned that I want to ask you about.
Sure.
The control arm and the maintenance or approach to maintenance. Control arm in terms of, you mentioned sorafenib, obviously we've talked about Midostaurin, and then I think you mentioned that there wasn't crossover for the control arm in the Quantum First study. And so I wanted to get your thoughts on how you thought about that and when you were designing the trial. And then in terms of maintenance, you mentioned that there's a different length of maintenance in the RATIFY and Quantum First trials. And obviously we hope that we're curing people of AML. And so I wanted your thoughts generally about maintenance in the curative setting, and then, how long is a piece of string? How long should we give maintenance for?
Yeah, for the first time, a FLT3 inhibitor has been approved for maintenance therapy. Quizartinib is approved as post-chemotherapy maintenance. It wasn't actually approved as post-transplant maintenance. And that's a change in the treatment paradigm. So if you're using Quizartinib for definitive therapy, as was done on Quantum First in a good number of the patients, not everyone went to transplant. Two things I would point out are that the survival of patients who went to transplant was better than the non-transplanted patients. But if we looked at the non-transplanted patients, Quizartinib was better than placebo in that group as well. And we can't say where that benefit comes from. Is it just, from induction? Is it consolidation? Is it maintenance? We didn't have subsequent randomizations to say. We would have needed a much larger study to really definitively answer that question. Double factorial design, something like that, requires a really big study. And Quantum First screened over 3,000 patients to find the study group, but it only randomized about, I want to say 539 or so patients at the end of the day. So we just don't have that many data points. That being said, I'm happy to have the drug in that context. And the question is going to be, are people going to use it exactly as it was done in the study, or are they going to mix and match, use it as post-transplant maintenance, switch to maintenance sooner, or not use maintenance at all? Because we don't have a definitive study saying maintenance is beneficial, we really don't know. But it also was tolerable, which is helpful. The thing to know about Quizartinib, though, is if you're going to use it, you really got to pay attention to the dose and concomitant medications, because it's a drug that's known to prolong QT. You really shouldn't be using it in patients who have baseline QT prolongation. And if you are using it, that's a dose-dependent phenomenon, and the drug levels are predictive of the degree of QT prolongation. And you have to adjust the dose based on concomitant medications, notably azole antifungals. Those tend to increase drug exposures, and they are associated with longer count recovery, which we generally saw on Quantum First, is that it took longer for patients in the Quizartinib arm to recover their counts from induction by about a week. So while we think that that's not associated with a detriment in long-term outcome, there was a higher rate of infections during induction on the study. There was a somewhat higher induction mortality, again, that may largely have been driven by the older patients. But you really got to pay attention to that. And the dose in maintenance is different than the dose used in combination chemotherapy. So, and then the approved dose is also different from what was used on the publication. So that's the last part about this you have to pay attention to. They use the free base of the drug rather than the hydrochloride salt to come up with the dosing of Quizartinib. So it's a little bit confusing. But on the study, how it was done, we used 40 milligrams in induction and consolidation. We used 60 milligrams in maintenance therapy. And in anybody taking a strong CYP3A4 inhibitor like voriconazole or posaconazole, the dose of quizartinib was cut in half.
So right now, if a patient who is intensive therapy candidate, do you choose quizartinib or midostaurin?
I certainly, want to look at giving the best therapy from day one to a patient who is eligible for, what I think has the best outcome data, which in younger patients, I think, to my eyes, the data are pretty clear that quizartinib should be the drug of choice. Why do I say that? Based on no randomized data, quizartinib versus midostaurin? I think if we look at the preponderance of the data, it's not driven by CR rates because they weren't all that different on the studies. And we're using the same definition. But what we do see is once patients go into remission, there seems to be better protection from relapse. And whether that is a function of people going to transplant, post-transplant maintenance, or the drug itself is a little bit clear because practice patterns changed. But what I can say is that if we look at the hazard ratio for survival on RATIFY for the FLT3 ITD positive group, it was about 0.8 regardless of the allele burden of FLT3 ITD. It was 0.68 in quizartinib, and if we look at the overall survival of comparably aged patients, again, the overall survival at 4 years on RATIFY was about 51% for both the FLT3 ITD and TKD positive patients. And it's closer to 60% for ITD only if you look at the under age 60 on Quantum First. So yeah, again, big grain of salt comparing studies in this setting, but at least the preponderance of the data say to me, this looks like a better drug. And it also has single agent activity. It's a more potent FLT3 inhibitor. I think that I can feel more comfortable saying we're really getting the job done with quizartinib. In particular for the question of maintenance, I really don't know that there's a lot of benefit to midostaurin maintenance, and there may be benefit to the quizartinib maintenance. Ironically, I do think there actually is likely a benefit to the post-transplant maintenance, though the FDA didn't approve it for that indication. And we know that actually better from the Morpho study, which I'm sure we'll talk about at some point.
I want to ask about one more study. Although we have, 2 trials which are positive, but we also had one negative trial, phase 3 trial, which is gilteritinib plus azacitidine versus azacitidine alone in intensive therapy ineligible patients. So I wanted to know your thoughts on the trial. I think even though the CR rates were significantly higher, 58% in the gilteritinib plus azacitidine arm versus 26% in azacitidine alone, but that did not translate to the overall survival. Overall survival is essentially the same.
Yeah, we were all disappointed by this result, I have to say. I used to present this study that was led by my good friend Eunice Wang, and I would put up a slide of Charlie Brown getting the football pulled out from under him, and at her egging, I have taken that out of my slide deck because I feel bad that she has to present the data and make this reference every time. But we were all really hoping for something very different from the Lacewing study is the name of this study, comparing azacitidine to azacitidine plus gilteritinib. I would point out there are some discrepancies in terms of how we'd like the data to turn out that may be driven by how the study was just designed. It's not a placebo-controlled trial. So patients knew what arm they were on because they were either receiving AZA alone or AZA plus gilteritinib, and that was open label. Gilteritinib was approved while the study was enrolling. And so if patients weren't happy with what they were receiving, they could drop off study, get gilteritinib and get azacitidine, and they often did. And so in that setting, I'm not that surprised that the survivals looked very similar across the 2 arms because there was a significant number of dropout from the study to get FLT3 inhibitor. Now, that being said, the event-free survival on the study is the same. The overall survival isn't as long as we would like. I don't think this is a home run. But if we look at some of the higher risk patients, those that had high allele burden of FLT3 ITD, it does suggest that there may be a benefit of the AZA plus gilt regimen. And I think that's a question of how driven by FLT3 are these leukemias, which can vary from patient to patient. And also the fact that it's hard to have a patient with proliferative disease treated with azacitidine alone. It's not at all surprising that the duration of azacitidine in the control arm was short, because I don't think that's very good therapy for those patients. And it probably led to physicians steering patients with less aggressive disease to this trial, because they knew if they got assigned to the azacitidine only arm, they really couldn't treat them with that. So, it's not really representative of what we see in the clinic, where we often have these patients with really explosive disease that's so characteristic of the FLT3 mutated cohort. So whether this is representative of what, what's best for this population, I really can't say. I am heartened by the fact that we do have active therapy in this setting, and I don't think AZA plus GILT is bad treatment. I have used that or a similar regimen in many of my patients. Again, particularly those who have high white count when they present. If we can knock that down with a therapy, any therapy, and a FLT3 inhibitor is quite good at that, then we can look at other treatments down the road, or if that's tolerable, we just continue it. I've also switched people to AZA-GILT if they've had trouble from cytopenias from, say, venetoclax azacitidine. That allows me to keep the azacitidine going longer and add a TKI if, for example, they still are testing positive for FLT3-ITD. Commonly, these patients have short remission durations from aza-ven, even though the remission rate's actually pretty good. It's about 70% with azacitidine venetoclax. And then that brings up the whole question of triplets. So that's like the hottest thing right now is, put all your eggs in one basket. If 2 drugs are good, 3 drugs must be better. But the simple answer is, the response rates are extremely high. They're every bit as high, if not potentially higher, than intensive chemotherapy plus a FLT3 inhibitor, which I think brings up some really interesting questions. If this is if this is hard therapy for older patients because it is myelosuppressive, and it is, then, what about myelosuppressive therapies for younger fit patients? We now have ways that we can measure these treatments with MRD to say, if we're getting comparable remission rates, but we're getting deeper remissions with one than the other, that might be a good way to compare these 2 therapies. And while we're largely testing these triplets, the azacitidine venetoclax approach with gilteritinib, in older unfit patients, I don't think it's outrageous to say, we really should be moving that therapy into younger or more fit patients if it is just as active and might be more tolerable, because I think that's a win for the patients. And we don't know. I mean, it could be no different in tolerability, and it could be no better in efficacy, but I think we will need to do a randomized study to clarify that. And probably, the community is going to need to see really from multi-center studies, how does aza-ven plus GILT play out in the older population? Those studies are ongoing right now. We're participating in a multi-center trial of that triplet called Viceroy. So that's currently enrolling at my site and a bunch of others.
All right, so now we'll move to relapsed refractory FLT3-positive AML. So as you know, several agents, including Quizartinib, gilteritinib, and crenolanib, they have promising activity, but only GILT monotherapy has received regulatory approval. And the approval was based on the Admiral study, which you led, and your publication in NEJM 2019. It was a phase 3 randomized trial evaluating single-agent gilteritinib compared with investigator's choice for patients ineligible for intensive salvage. So can you give us the top-line results of that study? Maybe we can do the efficacy first and safety after that.
Sure. So just to clarify the study population, this was first salvage for patients who were either refractory to whatever their treating physician thought was the best induction regimen. We didn't require that that was intensive chemotherapy, but they needed to have been given it in an attempt to go into remission, or they had relapsed after a prior remission achieved with any therapy, including patients who'd gone on to transplant and had a lot of prior therapy. But it wasn't for relapsed refractory patients who'd had multiple lines of prior therapy. It was their first salvage. So we thought that that would select for a group that might have some response to salvage chemotherapy, and that was the right population to declare whether gilteritinib was as good, better, or not as good in a randomized fashion. So the study enrolled, I think, 369 patients and randomized them 2-to-1 to either single agent gilteritinib, given at a dose of 120 milligrams, with allowances to decrease the dose if you had toxicity or increase the dose if you didn't go into remission with that dose. The investigator had to choose the appropriate salvage chemotherapy regimen from a choice of 4 options, 2 of which were intensive and 2 were low intensity, before randomization. So you had to just, cast your nickel before the patient got randomized, and they would be assigned to whatever you picked as what you thought was the best salvage chemotherapy. And that could be low-dose cytarabine, it could be azacitidine single agent. This predated the approval of venetoclax, so that wasn't included. On the intensive arm, patients could get a multi-agent regimen, either FLAG-IDA, or I believe MEC chemotherapy, mitoxantrone and etoposide, and intermediate dose cytarabine. And the primary endpoint of the study was overall survival, although we collected response data and transfusion independence as well. Again, the study enrolled over the period of like 2016 to 2018 or so, and then it was an event-driven readout when a certain number of patients had had a survival event, and that showed that the survival of patients treated on the gilteritinib arm was superior to that on the salvage chemotherapy arm. And when we looked at subgroup analysis, that benefit held up regardless of whether patients were older, younger, had been treated with, would have been treated with intensive chemotherapy as their salvage choice or low intensity therapy. It really held up across pretty much every subgroup we could define. The other thing I should point out is that the drug actually got approved before the survival readout was finalized, but the study had completed accrual and was just waiting for that to happen. And the reason why was that the clinical benefit of the drug had already been established, that as a single agent from both its phase 1/2 study called Chrysalis that I also led, and from the gilteritinib arm on the Admiral study, the response rate, including full CRs or CRHs, that were associated with adequate count recovery or full count recovery and transfusion independence, clearly met a threshold for clinical benefit. And it was approved based on that. About a third of patients developed transfusion independence, even though they'd been transfusion dependent prior to gilteritinib therapy. And the majority of people who were transfusion independent going into study maintained that throughout therapy. And that was over an 8-week period that they didn't need platelet transfusions. So it was fairly stringent. So the drug got approved after both, the demonstration of clinical benefit and then the survival data kind of clinched that. And it's now the standard of care for relapsed refractory AML with a FLT3 mutation. And it's important if somebody has a relapse that you confirm that the FLT3 mutation is present, because that's how we define the study population. You needed to have a FLT3 mutation, a TKD, or an ITD at study entry. It didn't matter what you had at initial diagnosis. And indeed, some people relapse with a new FLT3 ITD that wasn't there at initial diagnosis. And similarly, if a patient had a FLT3 mutation at initial diagnosis, they may not have it at the time of relapse. And we don't think the drug's very active in that population. It was studied in the Chrysalis study in patients regardless of genotype, and nearly all of the responses occurred in the FLT3 mutated group. So you really should screen for a FLT3 mutation before starting gilteritinib, not just because it's on the label, but because that wouldn't define optimal therapy for the patient.
Any major events to monitor while on single agent gilteritinib, like differentiation syndrome, for example? Can you allude more onto that, and what clinically, how do you manage that?
Yeah, that's an important question because, no drug is without side effects. I mentioned Gleevec before, and we think of, the wonder drug that it was in terms of just being so symptom-free relative to established CML therapies. And the same is sort of true of gilteritinib. It's a relatively easy drug to give patients. We give it in the outpatient setting. Certainly looking at the difference between, FLAG-IDA and gilteritinib, that's a no-brainer in terms of toxicity. So it's much, much, much less toxic than a comparator chemotherapy like, high-dose RSC-based regimens for salvage. That being said, no drug is without side effects. Gilteritinib does cause cytopenias. Gilteritinib commonly causes LFT abnormalities. We often see an elevation of CPK, and that's probably not from muscle damage, but it has to do with turnover of CPK that relates to signaling from the CSF1R receptor, which is involved in turnover of CPK. Often we see elevations of LDH that isn't tumor lysis. So you can see these, lab abnormalities that may not be of clinical consequence. You mentioned differentiation syndrome, which we described actually initially with Quizartinib, but we think is a class effect of FLT3 inhibitors, particularly when given as single agent. And so we don't see this a lot in combination therapy, but we can see it not uncommonly in patients treated with single agent FLT3 inhibitors, that the drug works by clearing the peripheral blast rapidly. And over just a few days, the white count comes, crashing on down. But over the next few weeks, we can actually see patients develop kind of vague symptoms that might look inflammatory. And an increase in the circulating neutrophils typically happens 2 to 8 weeks later. In the context of, often fevers, we can see, pleuropericardial effusions. patient can develop organ dysfunction in the setting, and there have been fatal cases. So if you suspect it, we recommend treatment with corticosteroids if there are systemic signs and symptoms. And it can also mimic another side effect that we see with FLT3 inhibitors, which is a sweet syndrome like rash, which may be associated with fever. And whether that's, just another manifestation of, say, leukemia cutis that differentiates in the skin, I don't think we can exactly say, but certainly we do see those two toxicities and they can look very similar. For sweets like rashes, I just use topical steroids in most cases, and that's effective, but sometimes can use systemic corticosteroids if it's resistant to that. And in terms of other adverse events, you do need to monitor QT for gilteritinib, just like Quizartinib. It does interact with azoles that can magnify toxicity, but there's not a mandatory dose reduction for the use of azoles.
Now we have more studies regarding combining gilteritinib with venetoclax. We have a phase 1b study recently published in Journal of Clinical Oncology led by you and Naval Daver at MD Anderson. What is the rationale for combining venetoclax plus gilteritinib? Is just more is better, or is there a actual mechanistic?
So shout out to Jessica Altman, who's also a key investigator involved in the design of that study and kind of my partner in crime in some of the combination studies. So there was actually a rationale here. You mentioned the differentiation that we saw with single agent gilteritinib. What we saw in tracking patients responding to gilteritinib is that they would vary in terms of whether the allele burden of FLT3-ITD would drop. And we had, been involved in the development of a quantitative assessment of FLT3-ITD burden that led to the in vivo scribe assay that was tested on the Morpho study for MRD detection. And what we saw with single agent gilteritinib is there were people who had deep responses to the drug, but it was a relatively small number of patients, and they seemed to do better. Their survival was better. And so one of the questions we had is, how do we deepen the responses to a FLT3 inhibitor through combination therapy? And obviously the easy way to do that is just add more intensive chemotherapy, but we were more interested in, could we use less toxic therapies that would, have synergistic interactions? And it was known from preclinical work that venetoclax plus gilteritinib did indeed exert that synergy. Very nice work from Marina Konopleva's lab showing that with Quizartinib, but it's been shown with other FLT3 inhibitors as well. And so combining gilteritinib with venetoclax, the thought was we would induce apoptosis if we would combine these drugs together. And that's indeed what we saw. We almost never see tumor lysis with gilteritinib alone. We did see it in some patients treated with the combination. Again, we saw very rapid drops in the FLT3-ITD burden, and we followed these patients by single cell sequencing with the Mission Bio Tapestry assay, and really did see that the FLT3-ITD clones were cleared from the marrow in ways that we didn't typically see with gilteritinib alone. So it really does look like we get a qualitatively different kind of response to venetoclax plus gilteritinib as a doublet. And the question that arises is, if you add, that to azacitidine plus venetoclax, do you, deepen or prolong those kinds of responses? I think in the relapse and refractory setting, it's probably not necessary, although, certainly there's activity of that regimen. And I think choosing doublet versus triplet in that setting should depend on what you've previously seen. The venetoclax gilteritinib study, majority of the patients enrolled to that study had prior FLT3 inhibitors and yet responded to that combination. We didn't have a lot of data on prior FLT3 inhibitors from Admiral since so few patients had prior FLT3 inhibitor. And so I think the activity of it in that setting is important. And if somebody had not had Ven-Aza frontline, maybe the triplet would be the best option for them in the salvage setting. But I do think that the response and survival data look fairly comparable, and it's probably a little less toxic. So doublet is probably just as good.
One thing from the GILT plus Ven data mentioning about the toxicity, almost 97% of the patients had grade 3 or 4 toxicity, and majority were cytopenias. How do you mitigate the myelosuppression when you're treating this combination?
Yeah, this was something we learned as we went through the study. The main way that we dealt with this was we tried to give patients continuous exposure to gilteritinib. And again, this goes back to what we knew from treating relapsed refractory FLT3 mutated AML, again, from work that Mark Levis had done many years ago with, at that time, much weaker inhibitors of FLT3 that if you only partially inhibited FLT3 or inhibited for a few hours of the day, but not round the clock, the leukemia would grow through it. So we really wanted to, in the relapse refractory setting, give continuous exposure to a FLT3 inhibitor if at all possible. But we were checking marrows to make sure the patients weren't getting aplastic. And if they were, we would hold these drugs. We would shorten the duration of the venetoclax exposure. It was initially given for 28 days with a up to 2-week recovery period. We dropped that to 21 and then 14 days on subsequent cycles. So we would decrease the number of days that you gave venetoclax. And that begs the question, just how many days do you need to combine venetoclax and gilteritinib to see that synergy that's there? And the answer is probably not very many. So that's something that we're doing, in the frontline studies is once patients start responding, we try to cut back on the number of days of venetoclax to decrease the myelosuppression, because it's very clear that count recovery is delayed when we give the triplet. And you may need only a few days of overlap of these drugs to really see that synergy. And again, even do you need 14 days of gilt, 28 days of gilt, continuous exposure? Nobody knows in the frontline setting. This was all worked out in relapse refractory patients, and it may not be true that you need continuous exposure. If you think of RATIFY, that was with a weak FLT3 inhibitor by comparison to gilteritinib or quizartinib, and it was only given for 14 days, and yet it's active. And when the same study was done in a FLT3 wild-type population, there was no improvement in survival on that trial, the UNIFY study. So we really do think it's a FLT3-driven phenomena that we see. And short-term FLT3 inhibitor may be perfectly adequate. So there'll be upcoming randomized studies looking at different sequences and different regimens of triplet. We'll be doing that in the MyeloMatch study through the NCI in the future.
Let's move to talking about the Morpho trial, randomized comparison of maintenance gilteritinib to placebo over 2 years following transplant in 356 patients with FLT3 ITD mutated AML. The study failed to reach its primary endpoint of relapse-free survival, but there was a suggestion that patients treated with gilteritinib achieved a numerical but not statistically significant improvement in RFS, with the p-value as 0.0518. So could you run us through some of the key takeaways from the Morpho trial?
Yeah, we needed a bigger study. I think, everybody looked at that and said, 0.051, is that close enough or not? Yeah, I mean, the statisticians said it has to be less than 0.05, and we were not. So overall, we could not show that there was a significant improvement in relapse-free survival, which was our primary endpoint. And the reason we chose that endpoint was, again, the same issue that came up on Lacewing, that we thought with active salvage therapy for the placebo group, we would not necessarily see an overall survival benefit, and we didn't. So I think that's the reason why there wasn't an overall survival group, is that the control arm that got placebo likely got effective salvage because they were pulled off study to get it when they either had a relapse or they were found to have recurrence of MRD or something like that. So we could not show an overall survival benefit with our study design. In terms of the relapse-free survival, though, it actually showed very much what we expected it to show, which was the benefit of FLT3 inhibitor maintenance therapy was largely limited to patients who had had suboptimal control of their leukemia, either prior to transplant or early evidence of relapse after transplant, as measured by an ultrasensitive FLT3 ITD test. So this PCR-NGS FLT3 MRD that was used on the study, it's a very sensitive assay. It's much, much more sensitive than PCR, traditional NGS, really any other MRD assay that has been looked at in this disease. And we looked at it prior to transplant, which is different than all of the FLT3 inhibitor studies that were looked at in the sorafenib world, in the Midostaurin world, where they really didn't have those kinds of discrimination prior to transplant. And then we looked at it serially after transplant at the time of randomization and every 3 months for the 2 years of maintenance that we provided thereafter. And so we got a serial MRD assessment on these patients at multiple time points. And what we found is that if patients at either the pre-transplant or the first post-transplant pre-randomization sample were MRD detectable at any level, down to 10 to the -6th, they had a worse survival, and their survival was better if they were on the gilteritinib arm. If they didn't have detectable FLT3 ITD, there was no benefit of the drug. And so that, clarifies that transplant does cure a good number of patients who have FLT3 ITD. But if you have not had an optimal response going into transplant, or if right after transplant you convert from MRD negative to MRD positive, you need more therapy, and more therapy does improve their outcome in terms of protection from relapse. And that was an important endpoint on the study. There was an interesting analysis on this that has not caught a lot of attention, which is if you only looked at the patients that were MRD positive post-transplant, which is about 20% of the patients, and that included a certain number of patients who were MRD negative pre-transplant and converted afterwards. That was, of the 20%, 5% of those, about a quarter of them were actually newly MRD positive. The clearance of that MRD was better in the gilteritinib arm than in the placebo arm, but there were, 40% of the patients in the placebo arm who did clear it. So there's a graft versus leukemic effect. And I think what gilteritinib really does is it holds the leukemia stable during the time that's needed for that GVL to kick in. And it probably takes several months for that to happen, to get the patient off immunosuppression, to get the donor cells well engrafted and active and seeing leukemia. And because that takes time, and typically FLT3 ITD positive AML relapses quickly after transplant, that's why no maintenance is associated with worse protection against relapse, because those will happen very early on. We didn't see late relapses on this study, and even after the 2 years of therapy, we didn't see a big increase at that point of relapses when we withdrew gilteritinib. But we could actually go back and look and say, in the people who relapsed right after stopping their gilteritinib, was MRD detectable? And often it was. So if you are going to withhold maintenance therapy after transplant, I think it behooves you to monitor for the presence of FLT3 ITD post-transplant. So it's not just a question of looking once pre-transplant. I think our onus is to monitor these patients closely because we can intervene. And I wouldn't necessarily wait for a clinical relapse in those patients because of what I said before, that if we treat, we may not need to give lifelong therapy. And we don't know how long to treat with gilteritinib once we see response in anyone who's relapsed. The goal here should not be to give continuous therapy for years and years and years and years and years. We gave 2 years of therapy on morpho, and we did see certain side effects more commonly in the gilteritinib arm, a slightly higher rate of GVHD, chronic graft-versus-host disease, and a higher rate of infections. And again, that could have translated into some of the mortality data that we saw, where we couldn't show a survival benefit in terms of overall survival for the gilteritinib population. Some of that could have come from adverse events.
Yeah, it's an interesting way of thinking about it, like a bridge, not just to transplant, but a bridge to GVL, and having the time for the GVL to kick in.
That's exactly how I think of it, yeah.
Do you think the use of azoles affected the morpho study at all?
Oh, it clearly affected the drug levels. And use of azoles was actually location driven. So it's much more common outside of North America that people not only used azoles, but used them for a prolonged period of time. And we measured the drug exposures in terms of pharmacokinetics of gilteritinib, or drug levels, really, therapeutic drug monitoring. And the drug levels were higher in patients who had used azoles, and particularly high in patients who used strong CYP3A inhibitors, such as posaconazole, voriconazole, and less notable in patients who had fluconazole or isovuconazole. That was associated with greater degrees of myelosuppression. It was also associated with people withholding their study drug, trying to resolve the myelosuppression, and the worry is that might have contributed to relapse risk. So it was interesting to see that the relapse rates were different across different parts of the world in terms of the enrollment of the study. And the benefit of the drug was actually different depending on where you looked at it. In North America, there was a substantial benefit of gilteritinib post-transplant, but we really saw no benefit at all. The Asian countries that enrolled are Australia, Pacific Islands. We saw, if anything, the gilteritinib-treated patients did a little bit worse in Europe. So where patients enrolled was a significant determinant of how they did. And we think at least some of that has to do with, are the patients really the same? And they probably weren't the same. They'd had a lot more prior therapy going into transplant, on average an additional cycle and an additional month of time from documentation of remission outside of North America. So it may have been that the benefit of the transplant is different if, for example, the really FLT3-driven patients who relapse early have been weeded out by the time of study enrollment by just waiting long enough. And that may have led to relatively lower risk patients outside of North America. If we look at the control arm, the survival of the control arm was much better outside of North America than in North American sites. And I suspect that's the reason why.
Yeah, it's very interesting when you try and sort of patch together results from different parts of the world like that, because practice can be so.
It was
so
very
different.
eye-opening. Yeah, no two places practice transplant the same, is what we learned.
I want to ask, obviously we've talked a lot about Quizartinib and Midostaurin in induction. Obviously, you also mentioned sorafenib as being previously used in maintenance, and now we have gilteritinib in maintenance. So do you sort of, we talked a bit before about...
I wouldn't say we have. There's no label for it yet. It's commonly used, but just like sorafenib is commonly used, this is off-label. The only time it's really on label is if you bridge to a transplant in the salvage setting. And there, I really think it's very important to put the patient back on maintenance after the transplant. And we don't know the optimal duration. I think our experience from Admiral and from Chrysalis was before Chrysalis, the phase 1/2 study of gilteritinib was amended to allow post-transplant maintenance. We had no option. And so we pulled people off study and give them sorafenib maintenance because we were worried that they would relapse. And if they didn't get maintenance, we often saw those relapses within 2 months of the transplant. So, very, very quickly patients would relapse. So if you use a FLT3 inhibitor to bridge to a transplant, you really should look to put the patient back on a FLT3 inhibitor. And that's a different population from Morpho, which was a much lower risk population. I would not expect, 80% survival from CR2 transplants done with gilt salvage. We saw much lower numbers than that, although not terrible, more like 50% survival, but better survival in the patients who got maintenance than those who didn't, with the caveats that they're not randomized and they could, again, be different patients.
I wanted to ask, if you start on one FLT3 inhibitor, do you stick with the same FLT3 inhibitor if you are going to use it for maintenance or for as a bridge to transplant, or do you swap depending on the data set that you're using?
Well, I haven't. I mean, I've been using midostaurin since it became available, but I've not used midostaurin post-transplant maintenance because I think it's not very tolerable and it hasn't really shown a lot of activity. I think sorafenib data were more impressive, quite honestly. It's not to say it wasn't studied. It was studied in a study called Radius. It did have some activity. It was just less impressive. It's an open label study, relatively small numbers, 30 in each arm. But, even the 40 patients in each arm from the SOAR main study showed a really impressive protection from relapse on that trial that I think convinced most everybody that sorafenib was an active agent for post-transplant maintenance and really should be our default. This led to a lot of consternation about whether it was ethical to do the Morpho study at all. And, I think we pretty clearly showed that there is a subgroup that benefits and there's a subgroup that really doesn't. So at the end of the day, given about half the patients can't tolerate sorafenib because of side effects, I don't think we harmed patients by doing a placebo-controlled trial. To get back to changing horses in midstream, yes, I traditionally had used midostaurin with induction and consolidation. And when patients would go to transplant, I would give them sorafenib. When gilteritinib became available, if we could get it from insurance, we would give it after transplant. And often I was able to get it and still am. We'll see whether that changes now that Morpho is presented. But I also don't know what the company's going to do with these data. I mean, they were hoping this would be a registration study, and they're left with a p-value that's 0.051. So we'll see what happens.
Thank you so much, Dr. Perl. We talked about a lot of clinical trials, and thank you so much for walking us through the entire landscape of FLT3-positive AML. Any exciting clinical trials in newly diagnosed or relapsed refractory space you're eagerly awaiting results for?
Yeah, there's a few that have either completed enrollment or are just about to complete enrollment that are frontline randomized studies. And I mentioned that the Quantum First study, one weakness of that study was it enrolled right around the time that midostaurin became available, and it had been designed with a placebo arm as the control. And it's been criticized roundly for that reason. But in reality, there was no way to feasibly do a midostaurin control arm. We wanted to, but just there was no way to do it. It was a global study. Midostaurin was only available in the US. Most of the places that we thought would enroll to the study had no access. And the sponsor was not going to go, buy midostaurin and then have 2 INDs on the same trial. So there was no way that was going to happen. So now there actually are studies that have a midostaurin control arm that have either completed enrollment or are about to complete enrollment. These are a study in the US done through Precog called Pre-0905. And then a study done by 2 cooperative groups in Europe, the HOVON Dutch cooperative group and the AMLSG in Germany. That study is called PASHA, or HOVON 156, and they have a very similar design from the get-go. They're comparing 7+3 plus gilteritinib versus 7+3 plus midostaurin. The post-remission therapy is a little bit different, and the PASHA study is powered to detect event-free survival as their primary endpoint as a planned registration study for frontline gilteritinib. Whereas the precog study is looking at molecular endpoints. And again, we'll learn a lot about MRD with this approach, and see whether, with a more potent and kind of newer FLT3 inhibitor that gilteritinib is, are we going to get deeper remissions with adding that drug to 7 and 3? Or is it going to be that there's really no difference in the outcomes because they're both type 1 inhibitors? They do what they're going to do. The patients who respond are the patients who respond, and we can substitute one drug for another, but it's not the same as the relapse refractory setting where you really are leaning on the merits of the drug itself to do all the heavy lifting, and not to modulate a chemotherapy response, which probably is what FLT3 inhibition does in frontline setting. So those will be very interesting data, I think, when they read out. And we still are probably at least a year away from the readout from the precog study, and several years to read out on the Pasha study, just because that trial, just is completing accrual now. So it'll probably be a couple of years before we get the word on that. There's the MyeloMatch program that the NCI is putting together that is looking to optimize therapy with a molecular algorithm. In some ways, that's similar to what Beat AML is doing, and I know Beat AML has had some arms that included FLT3 inhibitors. I believe there's a triplet study they're looking at also. And again, that's multi-center, unlike just single-center data, which is all we have right now from MD Anderson. Lastly, there's some new drugs coming down the pike, and we'll see, are these going to be the wave of the future, or are we kind of going to work with the drugs that we have now? There's a covalent inhibitor that Fujifilm came up with called FF10101. We did a phase 1b study of that. There's a second covalent inhibitor that Biomea is just getting going in trials. Aptos has an inhibitor. A bunch of companies have inhibitors. All of these are pretty early stage, though. None of these has gotten to the point of, adding it to chemotherapy. The only drug that's really done that in terms of new drugs we haven't talked a lot about is crenolanib, which really, I think is a player. The challenge with that is we don't know whether that study is going to continue. They have a phase 3 study that's been slow to accrue, and I think the sponsor is, kind of make a decision. Are they going to try to see that to completion, expand to more sites, expand to Europe, or what, or is that development over? I'm hopeful, that we get an answer off of that study, because I think that's a good drug. It looks active, and it had very promising data from phase 1/2 setting in combination with frontline intensive chemotherapy. So I'd love to see the final answer on that, and I'm kind of hopeful that we'll get that from that trial, but we have to wait and see. But that's kind of where we are in the FLT3 world as of fall of 2023. It's an exciting space. There's a lot of cool developments that are going forward. Again, the triplets are really exciting, both in older unfit patients, but I hope soon in younger, more fit patients. We will hopefully optimize frontline intensive therapy. We're better defining how to use FLT3 inhibitors pre-transplant, post-transplant. We have not eliminated transplant from the armamentarium here because it really does improve survival. And what I hope is, as we do more MRD, we can better describe who are the patients who really need it. If you achieve an MRD negative state early in therapy, do you really need a transplant, or should we wait on those patients, give them consolidation with FLT3 inhibitor, and monitor them closely? And if they do happen to relapse, take them to a transplant in CR2. I'm not comfortable doing that just yet, but I think ultimately, those are the kind of questions we need to ask and gather data on, so we can better inform therapy. And hopefully we don't need transplant in every patient just because they're eligible.
Thanks a lot, Dr. Perl, for your time, and we look forward to having you again once we have these results of some of the trials you briefly mentioned about in the future.
Thanks so much for this invitation. This was fun today.
Thank you.
Thank you, Dr. Perl.
Thanks, Dr. Perl.